I'm doing the introduction on behalf of David, who isn't here. I have the honor to do the introduction. Dr. Richard Tsang is a staff radiation oncologist at the Princess Margaret Cancer Center. He's been there since 1990, and he's also a professor at the Department of Radiation Oncology at the University of Toronto. Dr. Tsang is also apparently a Bee Gees fan, which is entirely appropriate since their signature song is Staying Alive. And I like that too. His clinical and research interests are in hematological malignancies, including lymphomas and myeloma, advanced imaging techniques, and also in precision radiation therapy. And Dr. Tsang completed his MD in Ottawa. He was a resident in Ottawa and in Toronto, and was a research fellow in London, England. As a doctor, he's a most kind gentleman, and I have experienced that personally as well. Radiation treatments have helped many of us in the support group. Last year, for example, Dave experienced increasing leg pains in his left leg due to a myeloma mass in his sacrum. Dr. Tsang's treatments eliminated these pains entirely. Bob had much pain relief in his spine soon after he had radiation treatment. Bob may mention something about that after the presentation. Thanks, Dr. Tsang. Dr. Tsang very generously took significant time out of his busy schedule to prepare today's presentation and to join us today to present it. With that in mind, please give Dr. Tsang a most warm welcome. Yeah.
Thank you, Jan. Thank you for your kind introduction. And thank you, Jocelyn, and members of the steering committee, and of course, David, for this kind invitation. So this is sort of a radiation 101 as it applies to myeloma. And not everyone with myeloma needs radiation because the mainstay for myeloma treatment, as you all know, is chemotherapy. At Princess Margaret, probably from our practice experience, only about 50% of patients would need radiation in the trajectory of the myeloma illness. And so I just want to highlight where we may be able to help with radiation and what situation and under sort of what circumstance, and also what it involves, and also the side effects of radiation treatment. And but it's actually not a scary thing. It's actually under the right circumstance, it provides substantial benefit, and also help quality of life, among other things, and the control of the myeloma. So I have no conflicts of interest to disclose for the purpose of this presentation. So myeloma is a systemic disease, and there is a localized form of myeloma. So I just sort of like to say that right at the beginning. And but that's only in 5% of people, and we call this condition a solitary plasmacytoma. So when the marrow is not involved by myeloma, there's not multiple lesions, but just one lesion, usually in the bone, could be in the vertebra, in the spine, could be another bone. But that only happens in 5% of people with plasma cell diseases. So the majority of people have systemic myeloma that requires chemotherapy, but out of this 5% with a solitary lesion, radiation has a pivotal role, and it actually may cure the disease. Yeah. So that's sort of the infrequent finding that we sometimes see in people rarely having this localized situation where we would give radiation by itself. Okay, so what does it look like? This is a bone marrow microscopy slide of the bone marrow. On the left-hand side, it's a normal bone marrow. As you probably all know, there's normally a good amount of fat in the bone marrow. That's all the white circles around here. And the cellular component is all this purplish pink stuff. On the right is a bone marrow occupied by myeloma cells. So they're very typically blue staining and very characteristic. And Variably, 60% of the marrow is occupied, up to 90, 100% of the marrow, crowding out all the normal cell production. So that's why people involved in this condition get anemia, get low platelet count, has poor immune system because the white cells are crowded out. So that the normal defense mechanism are weaker, and anemia would cause general symptoms of fatigue and lack of energy, etc. And platelets could be low, and that would cause bleeding. So overall, there's been substantial progress in the treatment of myeloma. So SEER is a large US database of all cancers, and it's often used as a sort of a bird's eye view on what's happening for specific cancers, plotting survival over time. And as you can see in the last 2 decades, there's a pretty good improvement in survival rates. And of all comers, anybody diagnosed with multiple myeloma, at the moment, we're sitting just above 50% for 5-year survival. So, and that's, a doubling of the survival rate compared to the 70s and the 80s. This is predominantly due to better targeted drugs with chemotherapy treatment. So I'm not going to talk about that, but many of you would know that probably even better than I do in terms of some of these very, very innovative and new drugs combinations that have improved the sort of expectation of response and also survival for the disease. So first of all, just some sort of very basic concept about radiation. Basically, radiation is a little package of energy that does not have a mass. So it's not a particle. And they're actually electromagnetic waves, not too different from electric waves, radio waves, and ultraviolet, and then X-rays. Diagnostic X-rays sits here. Gamma rays is therapeutic X-rays. So they're highly energetic with a much shorter wavelength and high frequency. And so this is what we are using when we talk about radiation treatment for myeloma. Gamma rays used to be harnessed from radioactive substance, for example, cobalt-60. There's a natural radioactive substance, and we put it in a machine, and then it emits the gamma ray and direct to the patient. But nowadays, we don't use cobalt machines anymore. We use machines called linear accelerators, which I'll show you a picture later on. So gamma rays, why does it work? So radiation actually damages and kills tumor cells. So the mechanism that of DNA damage is very similar to traditional chemotherapy drugs. So when DNA is damaged, cells cannot reproduce, and then the cell death occurs over a period of time. So the effect of these treatments, chemotherapy or radiation, are not immediate. It takes days and weeks to manifest. And typically 2 or 3 weeks, you may see a response. And the question is often asked, well, radiation can also damage normal cells. So how does it work? Why does it work in favor of the patient? Well, radiotherapy, the way we give it, exploits the difference in response of tumor cells versus those of normal cells. And in general, tumor cells proliferate quicker than normal cells. And that's why radiation, the general mechanism of how it works, it damages more the proliferating cells, that is the tumor cells, than it would for quiescent cells, which are the normal cells. And by varying the daily dose and also the amount of radiation each day and how over what period of time is given, we exploit it to the best benefit depending on the location of the myeloma or the organs that we're treating to get the best differential. Damages more the tumor cells and damaging least the normal cells to be within the safety level. And basically throughout the body, there are sort of these known damage levels for normal organs that we have to keep within, we call tolerance, so safety limits. So that's the science of radiotherapy. So that's my job, to make sure that when we give a course of treatment, that we get rid of the tumor or control it very well and give minimal damage to the normal organs, tissues, and structures around what I do. And we exploit that based on these different radiobiological sensitivity rates of tumor cells versus normal organs, and also by geometry, which I will demonstrate a little later. So inherently, the good thing is myeloma cells are very radiation sensitive. So I plotted this as a graph, as a scientific experiment of in a tissue dish of prostate cancer cells versus myeloma cells. So cell viability, 100%, if you give zero dose, there will be no damage to these cancer cells. If you give 200 centigrade or 600 centigrade, there's a dose response. The more dose you give, the more cancer cells you kill. But you can see that, for the same dose, a lot more myeloma cells are killed than prostate cancer cells. So this illustrates that in prostate cancer, doses that are required for treatment is like 60 gray, 70 gray, upwards there. But in myeloma, we can give 20 gray, 30 gray, and have good eradication. So if we can give 60, 70 gray and still be within safety for prostate cancer that it's located in the pelvis. So it just goes to show that side effects from giving treatment for myeloma when the dose is only required 1/4 of the dose of more maximum doses that we can give for prostate cancer, that is, the side effects are really quite minimal. So just an illustration, and these are the sort of the dose ranges that we use in the treatment of cancer. Okay, so when will radiation help? I mentioned already, in the isolated situation, radiation treatment may be curative. Unfortunately, this is a minority situation. There's only 5% of people who has myeloma who have the solitary type, and most people would need systemic chemotherapy as the mainstay treatment because it's multiple and one cannot direct treatment all over the body with radiation. So the typical scenario where we may help myeloma patients with radiation is for bone pain. And this is, I emphasize this is despite the ongoing chemotherapy, because chemotherapy or biphosphonate, like palmitonate monthly treatment, that they all help bone pain, and also analgesic drugs as well, so painkillers and things like that. So bone pain for myeloma usually helped by traditional treatment, but if there's an area of breakthrough or recalcitrant symptoms, then that's when we use radiation. Nerve compression, and the biggest one that we need to be sort of the most aware of is the spinal cord. And if there's one takeaway message, and I'll go over the symptoms of spinal cord compression later on, if there's one takeaway message for people with myeloma, is be very aware of seeking help if you develop symptoms that indicate spinal cord compression, because that's a very urgent medical condition that time is of the essence in order to try and get this treated to minimize long-term damage on the spinal cord. So, and then other unusual situations, masses compressing the orbit, for example, that causes vision impairment. And sometimes we also see large, what we call plasmacytomas, which is a tumor lump from myeloma, not just like a bone spot, but it's actually a soft tissue tumor mass, which presses on organs or tissues around it, produce pain, produce organ dysfunction. That's another scenario which sometimes would be helped by radiation treatment. What does it look like? So this, I treated this patient more than 20 years ago, and this is a chest X-ray. So all the black is the lung tissue. The heart is over here, and the diaphragms are here. So the head is here, the right shoulder, the left shoulder, and this shadow shouldn't be there. You should see that, on the other side, that's the normal appearance. So this is a plasmacytoma arising from a rib that presses into the thorax and compresses the lung tissue. So this happened to be a large solitary lesion, and it was treated with definitive radiation treatment, and the patient was cured. I followed him for 20 years and has stopped coming for follow-up now. So that's the scenario. But again, it is not a common scenario, but where we have it, the radiation treatment will be a definitive treatment, and this patient did not require chemotherapy. Okay, so that's one scenario, but infrequent. The more frequent scenario would be bone pain. So again, I sort of touched on this already. Other effective treatments are bisphosphonates, chemotherapy, steroid hormones like dexamethasone, which is in a lot of chemotherapy regimens, and obviously analgesic medications, from simple arthritis medications like Celebrex to narcotics if the pain is severe, like morphine. And then there's radiation treatment, and occasionally surgery is required. And for the spine, there could be a very effective pain relief treatment called kyphoplasty, which is done by usually radiologists or neurosurgeons, where a collapse of the vertebra results in pain, much like osteoarthritis. And the radiologist would inject what basically cement into the vertebra to build it back up again. And that is a good pain reliever where pain is due to the collapse. If pain is due to actually a plasmacytoma pressing on structures and the spinal cord or the nerve, kyphoplasty won't work. It would be either surgery or radiation that's required. And obviously, sometimes if the lesion in the bone, in a weight-bearing bone typically, causes a fracture of that bone, radiation would not fix that. And then you would need surgery, as in this case. So this patient had a fracture of the femoral neck, the femur bone, right across there. And the treatment for that is a artificial hip joint. So, yeah, so that's usually these procedures are done by orthopedic surgeons, and usually because the patient would experience an acute pain and cannot walk, and he or she could hear a crack and then cannot walk, and then you head straight to the emergency department, and orthopedics will assess, and this usually is the procedure for the surgical neck. In another location, it may be plate and screws, so we call that surgical internal fixation. And sometimes, depending on what's found, there may be a need to give radiation afterwards, because surgery usually fixes the fracture, but do not take away completely the myeloma or the plasmacytoma, whereas radiation will be able to control the myeloma in the bone so that the screws doesn't loosen up in time and become a problem. So, okay, so some of these treatments, therefore, when I went over these, are not mutually exclusive, but could be complementary. Yeah, okay. When to consider radiation therapy for bone pain. So when I see a patient, these are the things that I try to sort of highlight or get to the bottom of before I say, okay, let's do radiation. So it's despite drug treatments, the pain is affecting activities of daily living. So if you have a mild pain and you can carry on, and you take a Tylenol and you're fine, then maybe we shouldn't give radiation treatment. But if it's affecting your activities of daily living and affecting your lifestyle, and it's persistent for a period of more than 10 days, 2 weeks, and it doesn't seem to be going away, then the radiation can be considered. Not controlled by painkillers, particularly strong painkillers. If you're on morphine already in a significant dose and you're getting side effects from it, for example, then you want to see if radiation can release the necessity of taking too high dose of morphine or hydromorphone or other narcotic drugs so that you don't get side effects from the narcotics. And then mentioned this already, when there is significant nerve compression and the nerves, which could result in weakness of the muscles or numbness in the body. And I'll show you a picture later on sort of what to look out for. I put this in organ function, usually by masses. And recently, within just like last 2 months, I treated 2 patients with this condition. A mass sitting just below the liver, causing obstruction of the bile duct, just like like a gallbladder stone, causing jaundice, and that's, you know, that's a serious condition, obviously, because if you have jaundice for a long time, the liver will fail and be a big problem. So that's a situation where radiation may be useful. Okay, so spinal cord compression. What are the warning symptoms? Rapidly escalating pain in the spine over a period of several days or a week or 2 weeks. Okay, so that's a warning sign. Pain coming around to the front. So pain in the back, but then it radiates or get referred in a band-like fashion to the front of the chest. We call that reticular pain. You know, pain is felt downstream in the nerve where it was pinched. So it's pinched in the back, but you feel it in the front because the nerves come out the spinal cord and wraps around following the rib to the front. So people feel that the pain in the front. And particularly when you cough or when you sit in the toilet and strain, and the pain comes like that, that's a very typical symptom that there is some serious compression of nerves in your back. So, and then numbness. The typical numbness pattern is what's shown here, below a certain level. So I took this picture because we count the thoracic vertebra. There's 10 thoracic vertebrae. And the 10th one, the nerves come out at the level of the belly button, the umbilicus. So a T10, the 10th thoracic vertebra spinal cord compression level, would cause numbness below the level of the belly button. And, you know, this is quite different from if you get a little bit of neuropathy from the chemotherapy, your fingertips a little numb, your toes maybe a little numb. That's very different. But this is like numbness where you cannot feel the sharp of a needle, or step into the shower, you cannot feel the hot water. And the level is like a straight line, typically at that level as shown here, depending on the level. So if you have a high thoracic cord compression, it could be up to the level in the chest, okay? If you have a lower than T10, it could just be your legs. And in a more severe situation, in addition to numbness, your legs will be weak and you cannot walk. And the nerves also supply the bowel and the bladder, and then there's inability to urinate, so urinary retention or severe constipation. So these are constellation of symptoms, warning signs where we regard spinal cord compression in its well-established form as a medical emergency. So the treatment is either radiation or surgery to remove the cancer. And usually that's a big surgery with neurosurgeons being involved, and those are the 2 options. And often because of how sensitive myeloma masses are, radiation is the preferred approach, but in a very rapidly evolving situation, like, if the weakness develop over a day or two and it's quite severe, surgery may be the better option. So it depends on the situation, the choice between the two. Okay, what does pictures look like? So how do we react when we have a patient with suspected spinal cord compression? We get an urgent MRI scan, magnetic resonance scan. And MRI is best to look at the spine. So this is what we call a sagittal cut. So the top is there, the front of the patient is here, the vertebra lining up. This gray line structure is the spinal cord. So you see at this level, there is the mass causing and pushing on the spinal cord. The yellow cut here is what a normal appearance should look like. So you can compare this picture with this picture. All this extra stuff here, white, somewhat gray white looking, that's the myeloma mass with the destruction of the vertebra, which should look more like this. And the spinal cord with the white around it, with bath in the fluid, is compressed by elements of this mass. Okay, so that's what we do, and we get a picture like this. I would get the patient in same day and start radiation treatment. Okay, so how's the process? Most people with the condition of multiple myeloma would be under care of a hematologist with expertise in treating myeloma. And so a referral would need to be made to a radiation oncologist. And I mean, basically, as I sort of shown already, the decision to use radiation, the necessity of it is actually most obvious with a history, like symptoms, duration, what happened so far, and then supplemented by imaging. And that could be with plain X-rays. By the way, bone scans are not greatly useful for myeloma because bone scans showed neobone activity and not destructive bone activity a lot of times. And whereas myeloma causes destruction of the bone, so it's not shown very well on the bone scan. CT is good, MRI is good, particularly for the spine. And now where available, PET scan I also find very useful. Okay, so more examples of spinal cord compression. So, it's pretty obvious. It shows you the situation very well. And this is a picture of a PET scan. PET stands for positron emission tomography. So a PET scan is actually a combined PET CT scan. So the machine just looked like a CT scan, but it involved an injection of small amount of tracer sugar that is made slightly radioactive. And sugar is differentially picked up by cancers, not just myeloma, but other types of cancers too. So it's used a lot now in oncology. But in myeloma, you can see this situation. This is the patient with that T10 lesion that I've shown before. This sort of heat map with the orange intensity of pickup of the sugar by the lesion in the spine. And it's quantitative, how much of it's picked up there is measured by a standardized uptick value. So it's an intensive measure of the radioactive sugar. So the FDG stands for fluorodeoxyglucose. So it's a glucose that's fluorinated with, it's a slightly radioactive sugar chemical that get injected into your arm. And then you wait 45 minutes and then we take this image and this is what we see. Okay, so that's very useful. To localize where there's active tumor cells in myeloma. Availability, sorry, I'm just concentrating on the GTA area, but across the country, most cancer clinics would have availability for radiotherapy. But in the GTA area, obviously at Princess Margaret, this is where I work, Sunnybrook Hospital. Out west in Mississauga, there's Credit Valley Hospital, and out east, there's Lake Ridge in Oshawa. And north of the city, there's availability in Newmarket. The center is South Lake, and also in Barrie. I've been around, the Ontario system for quite a few years, and we had years where there's, wait lists for cancer patients getting on the treatment, etc. But, in the last few years, COVID aside, there's really no wait list. Yeah. And I mean, for COVID at Princess Margaret, across the board, we basically are trying not to sort of downsize or, reduce our activities at all during COVID. And we've been running at like 85–90% of normal, basically. And in hematological malignancies, it's 100%. Like we've not slowed down at all. Yeah. The slowdown is for other types of cancers where there's a certain level of fear about coming to have screening tests done or to have investigations or seek medical help despite symptoms. So there's, for example, there's been a drop in the diagnosis of breast cancer during COVID, and that's because screening for breast cancer with mammography had slowed down a little bit, etc. But in hematological, because people have symptoms and by and large, they're more rapidly developing situations, that there is, we try not to have sort of slowing down of care or reducing our activities in that area. Okay. How? If the decision to have radiation, what happens? So we always custom design each patient's radiation treatment because all our size, shape, anatomy is different. So there's a mapping CAT scan done usually with no contrast dye injection. And depending on areas, I'll show you later, that we may fashion a mask for the head and neck area. And for the body, we put small tattoo marks on the skin just to reproduce the treatment from day to day accurately, and they are reference marks. They're not, they're not placed exactly where the location of the treatment is. And the actual treatment takes about half an hour. It's painless. It's either a single treatment or sometimes 5 to 10 treatments. Those are the most established regimens that are used, and the treatment is done with a linear accelerator, or what's called LINAC, so linear accelerator. So from consultation to the simulation with the CAT scan to customized planning and the dosimetry and physics evaluation behind the scenes to radiation treatment takes about 2 to 5 days. And on the right-hand side is the linear accelerator. Okay, these are bulky machines. So how X-ray is generated here is not a radioactive substance like what I mentioned about the cobalt machines 20 years ago. These are machines that have a vacuum tube out here, which accelerate electrons at a very fast rate in a vacuum. And then there's a tungsten target sitting in the head of the machine, and the electrons hit a heavy material like tungsten, and then it gives off X-rays. And then why do we prefer this over a cobalt machine? Because it's more controllable. You can vary the energy of the X-rays coming out. You can collimate it well in a beam, and it's all computer driven these days. That was all the old cobalt machines are all like very manual. So so this is sort of what happens. This shows that the machine swings around the patient in this way and deliver the beam. And this is an old treatment setup with marks put on the skin, but now we use a mask and we put marks on the mask and not on the patient. Yeah, okay, so that's sort of how it looks like. And we only need to use the mask for head and neck areas. So how did we treat a spot? Generally, nowadays, it's all computer driven and computer planned. As a doctor in this area, I would outline that treatment area and give it a margin. And then I also outline, you see this line around this organ, that's the heart. So I say, this is a normal organ that we obviously want to avoid giving radiation to. And then we put some parameters into the system and ask the computer to generate the best arcs and the dosimetry to achieve what we want to achieve. Give a 30-gray dose to this area, but minimize the dose to the heart. And then we see like a topographical map of elevation. It's a dose level map so that these are low dose lines that are low dose, and then the prescribed dose lines are confined to the vertebra and surrounding involved areas. Okay, so 30 gray, it's a lot. A 1 gray, you might sometimes go on the old terms of rad. So 100 rad is 100 centigrade, which is 1 gray. So 30 gray is like 3,000 rads. So a gray is several hundred times more dose than a routine CT scan. So sometimes people ask me, well, doc, what are you giving me in comparison with just a regular CAT scan? So, and I'll tell them it's like, maybe a couple thousand times more than a dose you would get on a routine CT scan. So if you ever had radiation treatment on a specific area on your body, don't worry about getting too many CAT scans because that's very, very little compared to. So don't worry about getting too many CAT scans because that's not going to affect your organs or function at all because that's all very low dose. And the only issue about long-term effects of radiation exposure, that is if we live 20 years, 30 years past the exposure time, there's a very small risk of secondary malignancies as a result of radiation exposure. So there's that. Okay, but it's not a big risk, and that risk is not unique to radiation treatment exposure. It's also for a lot of chemotherapy drugs too. Yeah, but it's a small risk. It's not seen very frequently. So I use this situation to illustrate what visibly could be a response. So this patient had a deposit, and you can see the break in the bone with a soft tissue mass, a bump going out and pressing into the brain as well. And fortunately, it's a frontal brain area, which doesn't control legs or arms or have symptoms. So actually, despite a little bit of brain compression, the patient does not have any symptom from this, other than feeling a bump in the head. And treatments given, 5 treatments. 2 months later, it's basically gone, but there's still a void in the bone because the bone will take on average 4 to 6 months to reform there. And it may not reform completely. And you can see that on the picture that a bump becomes an indentation because the bump was due to the tumor. The tumor's gone, it indents a little bit. So, just jokingly, I told this patient, don't put your finger on that too hard because you're pressing on your brain because your skull bone is gone there. So there's the interest about that. So it just shows that, a little bit of radiation, not too high a dose, a dose, a pretty standard, useful regimen, is very helpful. So the expectation. So within the first day or two of starting a course of radiation, paradoxically, in about 20% of patients, the pain will worsen. And we call that a flare reaction. So I always warn people about this. They may need to continue taking their painkillers. And sometimes I would prescribe dexamethasone. So the steroid drug would help prevent this type of flare reaction temporarily, just a few days. Or we can coincide the radiation treatment with the very favorite dexamethasone regimen. Some of you may know is 4 days on, 4 days off, or 4 days once a month, or something like that. So to coincide the 4 days of dexamethasone with radiation treatment, that would prevent this sort of flare reaction. Okay, so within 1 to 2 weeks, we see improvement in pain for the majority of people. In the long term, the radiated bone will heal, and it would hopefully prevent it from fracturing in the future if it's a weight-bearing bone. And usually, we don't need to go back and treat the same area again. Usually, we have good control and patients pain-free or 80–90% better in that area for many years. In general, I also remind people that this is a local treatment only, so it does not affect the rest of the myeloma where there may be other lesions. And in the area of the treatment volume, it's repeatable once in the rest of your life. So due to, it depends on the location, but as a general statement, that's true, particularly for the truncal area from neck to pelvis, because the tissue remembers radiation and we cannot give too much of it over your lifetime. Yeah. In general, the expectations are that it will not interfere with chemotherapy. The main drug that we don't want to give radiation together with chemotherapy is a drug called adriamycin or doxorubicin, which used to be given for myeloma, but is rarely used now with the better innovative regimens and targeted therapy with Velcade or carfilzomab or, antibodies like daratumumab and things like that. So it's not a problem to get ongoing chemotherapy with radiation. In general, it does not produce a drop in blood counts or affect stem cells. The exception is if there's very large truncal areas of treatment, particularly in the pelvis, it may. So again, it depends on the location of the radiation, obviously, because much of our bone marrow production is centered around the pelvic bones and the spine. So it's fairly well tolerated for most areas. Again, I emphasize the treated bone will remain weak. So if it's the femur or the humerus, there's still a fracture risk for a number of months. So sometimes I would advise people to use crutches and, not to exercise in a jumping up or down motion to stress that bone, because that will increase the risk of fracture, even after radiation when the pain is gone. Yeah. Okay. Possible side effects. It's really location dependent. It's a local treatment, so it would produce predominantly local symptoms. So if it's in the neck area, if the salivary gland is exposed, there may be taste disturbance, there could be dryness of the mouth. If it's in the midline, in the neck, and the esophagus was slightly exposed to radiation, there could be swallowing difficulty, but these are all temporary, last a few days, and it should go back to normal. If large areas of lung get radiated, then there may be lung scarring, but we don't do that. Like we don't, we always protect the lung. So those are rare situations where we have to sort of treat in a large area in the thorax. Abdomen, the typical symptom is nausea and vomiting, and this is an acute symptom. So it's usually within a few hours of having received the radiation in the abdomen. So often if I am targeting the abdominal area or the spine, I would give antiemetic drugs, like drugs to prevent nausea, before the patient comes in for radiation. Like when they leave home, they can take ondansetron, for example, Sofran, and then come like half an hour to 1 hour before the treatment. In the pelvis, as I mentioned, it could affect blood counts. Any site that is hair bearing, in the skin, there may be a little bit of hair loss, which is temporary, but it will grow back. Mild skin redness could be seen, but it's usually very mild and even not noticeable with the modern machines that we have. With 20 years ago, with cobalt machines, we usually get a bit more skin redness, but not now. Fatigue is a general symptom that people do experience with any chemotherapy treatment, radiation, etc. And even just traveling back and forth for a week or two, it could be tiring. So that's that. Yeah.
Dr. Tsang.
Yeah. Okay.
Sorry, there was one question in the chat from Jan, who said that he's aware that for other cancers right now, for things like prostate cancer, etc., other focused beam therapies are developing, like high intensity focused ultrasound. Do you anticipate development of radiation treatment for myeloma to potentially include some of the new focused beam technologies?
Yeah, so there's non-radiation technologies. What I think you're referring to is HIFU, high intensity ultrasound for prostate. It hasn't really been useful for hematologic malignancies. And also in myeloma, the beauty of it is that we don't have to use too much radiation and have a great response, as opposed to prostate, where sometimes people even get doses up to 60, 70 gray and it still be a problem. And these other non-radiation approaches become a temporizing attraction in terms of its use. In terms of other sort of radiation technologies, there are focus beams called gamma knife radiotherapy, or tomotherapy. In general, I mean, we have that technology in Princess Margaret, but it's seldom useful for myeloma because most myeloma spots are not that small to be focused to like a centimeter or two. And that's what we're talking about. And so gamma knife is useful for very small lesions inside the brain, for example. So we have that, and like very rarely do we have to use it for hematologic malignancies like myeloma or others. Yeah.
Thank you.
So it's a good question. Yeah. And then what's coming down the planning in the province is what we call protons. But again, there we don't really need to resort to protons. They're usually for relatively resistant tumors to X-rays, or in pediatric type cancers where there may be a role there. Yeah, and right now there are no proton facilities in Ontario or in Canada, so we have a referral process for people to go to the United States if proton treatment is required, but rarely, if ever, that's required for people with myeloma. Yeah.
Great. Thank you very much.
Any other questions so far? I think
there have not been any in the chat at the moment. So
okay,
yeah.
Good. So I'm going to wrap up pretty soon, so then we can open it up. The follow-up procedures after radiation. Practically all side effects of radiation are transient and will recover pretty fully afterwards. So the follow-up is really assessment of pain, analgesic requirements, and then ongoing supervision to continue your systemic treatment, and then regular imaging. And if obviously there's if it was a spinal cord issue, then the CT scan or MRI scans could be repeated a few months later. In general, we're not very heavy on keep doing scans because the objective of the treatment is to relieve pain or to relieve neurological deficit. If those things are achieved, doing a scan doesn't greatly help. So that's what we do. And sometimes we also repeat a PET scan, depending on what information the hematologists require in terms of deciding about further treatment, because it sort of gives a good visual picture, like a visual picture of what's the degree of the disease activity based on the intensity of the uptake by like a whole body scan, because it's a good sort of one look at one image and you get a pretty good idea how things are. So I've been in practice for a number of years. So over the years, I've seen improvement in radiation technologies, and these are some of the things that have advanced that really we're seeing better results or lesser side effects because of these technologies. So more precise targeting means there's less collateral damage to organs and tissues around. Image-based 3D planning means that we can assess the dosimetry in a more scientific way, and therefore spare the surrounding normal organs of any unnecessary radiation damage. And then ways to sort of achieve that and then protect normal tissues. And so, so when I started out in practice, we define radiation fields by a wax pen drawing on an X-ray film, and then whole blocks of tissue get treated. And now, we define it by three-dimensional, taking full imaging with MRI, PET scan even into account, and define it well, assess dosimetry, and have quantitative assessment of what's safe, what's not safe, and therefore to everybody's benefit. Margins of treatment had sort of also closed down quite a bit by image guidance. So that's another topic on its own. So, but just to know that there's been so much improvement in all this that in a couple of years ago, 3 years ago, this is among doctors that treat this disease in the field. There's always a bit of confusion on what's the best technology and all that. So I was charged to get an international group together to more accurately define how we employ these technologies for multiple myeloma and solid tumor plasmacytoma. So this is, a good project that had, people in the field come together, that we discuss it and sort of have it published for the wider community to have a guidance on the best standard of practice for people with hematologic malignancies like multiple myeloma. So that's sort of, and I learned a lot during this. And in fact, it was this work when in 2018, when I started doing this, I looked in the literature and found that there's good evidence that PET scan is very useful in certain time points in patients with multiple myeloma, and also to make a diagnosis of the solitary situation. But the Ontario government did not have PET scan approved yet for the use of PET scans in this disease. So I went to the steering committee of the PET scan sort of group of doctors who decide who advised the government of PET scan funding and said, we got to fund the use of PET scan for people with myeloma. And I said, I'm also, and my group is writing this guideline, and we will put in a guideline for Ontario, Canada, around the world, that PET scan should be available as standard of practice under these indications. And so it was accepted. And it was since then that in Toronto and in Ontario, that we're able to order PET scan and not have patients pay for a private PET scan if it's required, funded by the Ontario government. So there's a little side story about this work. So yeah, so targeting and good treatments, and I thank you for your attention. And I think I'm sure you have questions, so we will try and address that. Yeah, so thank you for listening, and that's my email. And your group have any questions that come up afterwards, please feel free to email me. Okay, so thank you.
Thank you so very much. I know that Jan has another question, and then I'm going to turn it over to Bob.
Okay. I don't mean to hog the stage, but I do have one other question, Doctor. And okay. I think you kind of touched on it, but it pertains to the need for radiation therapy. If, say, for example, I get an MRI and a plasmacytoma is found, or a lesion is found, but it's not bothering me, and it doesn't look like it's going to interfere with any of my bodily functions. Does that mean generally that I go in a sort of a wait and watch situation, and that my radiation is either delayed or canceled?
Generally, yes. If you don't have any symptoms, there's usually no role for putting radiation to that spot, because when we do an MRI of a spine, typically we'll find multiple spots along the vertebra. And if there are no symptoms, the mainstay treatment with chemotherapy will look after the spots. But we occasionally do, like infrequently, would have picked up a significant mass despite no symptoms. If there's some concern with the hematology team that despite ongoing chemotherapy, this spot is not controlled or is enlarging, and there is impending location-wise pressure on the spinal cord or nerve, then despite no symptoms, there may be a discussion to be on the safe side to give it some treatment rather than to wait for symptom, because sometimes when the symptom arises, it could be very acute and very severe when there's pressure on the spinal cord. Yeah, okay. So it depends on depending on the mass. If there's a mass, soft tissue mass on top of the bone lesion, and it's close to a nerve or already pressing on it, then despite no symptoms, we sometimes will give treatment in that scenario. And that's usually a joint decision with the hematology team of doctors. And now obviously that's the situation, and if you're treatment naive, if you're not started chemotherapy already, we'll just start chemotherapy and then we'll look after it. But if you're already on second line, third line chemotherapy treatment, and there's still a very persistent spot, and it is 5 centimeters and not half a centimeter, then we might exert the decision to treat it rather than leaving it to expand and enlarge. Yeah.
Okay.
So, yeah.
Sorry, go ahead. Sorry. I was just going to ask as a follow-up. We talk about the size, very unscientific. What is a big plasmacytoma? A golf ball size, or a hard ball, or a softball, or
Yeah. So obviously size is a continuum. The smaller the better, the larger the worse. Okay, but in the area of plasmacytoma, anything 5 centimeters or more is significant, I would say. Anything over 10 is sort of pretty bad. Like, you know, if you have a 10 centimeter mass, almost for sure you're going to have symptoms. Most people who have 5 centimeter mass, depending on where it is, would likely have symptoms too. What is small, you know, 1 or 2 centimeters. Yeah. Yeah. So I would sort of give a lot of respect for anything that is 5 centimeters or more in a setting of continuing chemotherapy has not reduced it. Yeah. And how many years of follow-up time? Mostly it is in very young people, like in the pediatric group, like and also in teenagers or young adults. So it's less applicable for people in their 60s or 70s, but the risk is very small. And it's something that we think about a lot when we give radiation, or we have to recommend radiation for a young person. But I alluded to this earlier, some chemotherapy of many types have a very similar risk. Although the type of cancers are different, like if you get chemotherapy of certain, what we call alkylator drugs, like cyclophosphamide or busulfan, or some drugs that are used in autologous stem cell transplant, there is a small risk of leukemia, for example. So there's that. But whereas with radiation exposure is more solid cancers, and it relates to the location of the radiation exposure. Yeah.
That is encouraging news then. There is a question from Harvey Kessler. He's requesting an email address.
I'm going to type it in the chat box.
Amazing.
And just for the purpose of the recording, just for the sake of the recording, because we had paused it for a moment, the question that you were just answering was whether or not we can sort of anticipate potential side effects or long-term effects from radiation sort of many years down the road. So thank you so much for answering that.
Yeah. Yeah.
Okay. Any other?
So I just typed in my email address in the chat box.
You know, I think what's happened here is, Dr. Tsang, is you anticipated all of our questions when you put the presentation together, because the presentation was so well put together that any question I would have is essentially ingrained in the presentation that you made. But if there are any questions that anybody has, we have a few more minutes.
Okay. Yeah, I really thank David for that, because although he said he wasn't here, and he went through my presentation and gave me an email that I read this morning with probably 12 to 13 questions. And then I said, I'll try, and that's very good heads up so that we can sort of, they were all excellent questions. And so I tried to sort of deal with it as I went through. Yeah.
That's David. That's me.
1-800-CALL David. Yeah.
Bob, did you want to jump in?
I also like to thank everyone who had been in this fundraising effort for myeloma research, for all the, like Princess Margaret Walk and all your other walks for the Myeloma Canada. So that's great. Like, I mean, that's just so fantastic because in this area, there's still a lot of clinical research that's required. And many of you may know that we have 2 basic scientists, clinician scientists at Princess Margaret that does, really, really top-notch research in the area of myeloma. And that's Dr. Suzanne Cherdell and Dr. Roger Tiedemann, the two basic scientists that does this at our place. And not to mention the clinical investigators who run the clinical trials, like people like Dr. Reese and who leads the group. And so they do great work, and those are the people that I have the fortunate opportunity to work with all these years. Yeah.
Any other questions? Is the chat line clear, Jocelyn?
I didn't get that email address. I don't see it anywhere. Dr. Tsang's email address, please.
Okay, I typed it in the chat box, so it's Richard.Tsang, Tsang, at rmp.uhn.ca. Yeah.
Thank you.
Yeah, the RMP stands for Radiation Medicine Program, and then UHN is University Health Network, and then .ca. Yeah.
Thank you again.
Okay, no problem.